Good afternoon and welcome to ICE Webinars, a cool place for hot topics. Today we are joined by Jessica Chambers, Director of Clinical Operations at SSM Health. She has 22 years of imaging experience and oversees 3 hospitals and 4 outpatient imaging centres. Just a quick reminder to save the date for our 10th anniversary ICE 2024, which will be held at the Hyatt Regency in Irvine, California from February the 18th to the 20th. The Imaging Conference and Expo is the only conference dedicated to imaging directors, radiology administrators, and imaging engineers. ICE offers valuable CE credits from the ASRT and ACI and is a unique community of key decision makers and influential imaging professionals. Registration is now open, so for more details, please visit attendice.com. Today's webinar is eligible for 1 Art Category A CE credit by the HRA, and you can attain your CE certificate by completing the post-webinar survey. The survey will be emailed 1 hour after the completion of today's webinar, and you must complete the survey to receive your 1 CE credit. You'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll wrap up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on the webinar dashboard. Kate, let's kick off today's webinar by giving away one of our ICE gym bags to the attendee that can tell me the answer to the following trivia question. Halloween is almost upon us, so which movie features the Sanderson sisters, the fictional trio of witches? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. As I mentioned earlier, Jessica Chambers is our presenter today, and she will be discussing improving abdominal CT turnaround time in the emergency room. Jessica, you may begin whenever you're ready.
Thank you. And thank you everyone for taking time out of your busy schedules to join me today. I do want to disclose I have no financial interest in regards to this. And so a little about myself. I by no means call myself an expert in the imaging career field, but I have been around for about 22 years. I started in the U.S. Air Force as a radiology technologist and then earned my way up into CT tech. When I was discharged, I started a role as a CT supervisor and then gradually worked my way up through leadership and currently working in a regional position. So we all were faced with COVID-19, and there was one major incident that happened with COVID-19 that really impacted a lot of our hospitals. And that major incident, it depended on how it impacted you, whether you were a customer of one company or another company. And really that came down to a contrast media shortage. So some of you out there might have really been hurt with this if you were using GE contrast. We were fortunate with our organization that we were not on GE, but it still put some angst in all of us because we were worried, well, what if all these GE folks start trying to use the contrast we're using? And how is that going to impact us in many of the areas of IV contrast, oral contrast, etc.? How are we going to be able to provide care if there's a shortage of contrast because of the COVID-19 outbreak in China? So what did a lot of people do to get by? I'm sure many of us were frantically looking at ways to get by. As soon as I learned of this, I did exactly what everyone said do not do, but I went to all of my CT departments and said, you guys, everyone's probably going to start trying to get contrast, so over order right now. We have to go into stock mode and try to stock all of our cabinets. So we hurry up and tried to order, and it didn't take long for Bracco, that's who we were using, to come in and say, whoa, you guys have to stop this. We have to ration what we have. So that kicks you into the thought process of, are we going to reduce usage? Are we going to look at, do you really need 100 cc's? Can you get by with 50? What can we do to kind of reduce how much we're giving? Another question that came in is, what are you going to use for oral contrast? We're not using barium. Barium, not only does it taste terrible for the patients, it takes longer to pass through the digestive tract. So we had already transitioned to using the same contrast we inject as our oral contrast, just adding it to Gatorade or Crystal Light or something of that sort. So are we still going to use that to oral contrast, or are we going to revert back to kind of the olden days and reintroduce barium? And that would cause another issue with our patients who are used to drinking some concoction of Gatorade or lemonade or one or the other that we're giving them, and now we're going to have to give them this nasty barium to drink. So that was really something we had to think through. And so did you switch to barium to get through it? And I'm sure all of you on here with CT departments, I'm sure you went through this thought process of really deep diving into which one of these was your solution to the contrast shortage that we had. We luckily were already ahead of the game. We were very selective on our oral contrast usage, so that kind of became something that we weren't really looking at, and we weren't dosing everybody, which we'll get into a little bit further into this presentation. But it really got us to think of, have we slipped on compliance? Any of you that have been through process improvement, you know it's kind of when Big Brother's watching, whenever you implement something new and you're auditing it and you're looking at how you're progressing with the change. In the very beginning, you're doing great at it because everyone knows that we're coming in and checking on it. But then once we kind of hit that goal and we know we're doing great and we monitor it for a little while, things start to slip. So even though we were already very selective on our oral contrast usage, we decided that we needed to kind of look and make sure that we hadn't slipped on compliance, which made us look at this process all over again and make sure we were where we needed to be. And so we really wanted to do some re-education, and that kind of sparked us re-looking at this process of who gets oral contrast and who does not. So with that, this kind of just stems all the way into what is oral contrast used. It's for our abdomen and pelvis CTs. And the thing that delays us most in the ED when we're looking at abdomen and pelvis CTs is exactly that. It's your oral contrast. The CT itself, we can't really get very much quicker on the scanning of it. Even as newer scanners come out and they scan faster, you really can't cut down your scan time because the longest part of a CT really isn't from start to finish of the actual table time. It's getting the patient on the table, it's hooking up their IVs, it's if you have the electronic health record, which I'm sure 99% of the people here do, it's all that minutia you have to do in the electronic record that we didn't have to do on paper. All of that adds time, and you really can't shave any of that off. So when we're talking about the dreaded abdomen and pelvis CT, the big culprit is the oral contrast. That's what's eating up most of our time, and it really comes down to that drinking protocol. And as I've spoken to other organizations outside of my organization, as I've been with my organization for about 16 years, the time of oral contrast has changed. When I first started, we really were at 120 minutes. We were waiting that full 2 hours. Make sure that contrast gets all the way through before you scan, which really can delay those patients coming through the ER. So we've kind of transitioned. Is 90 minutes the golden number? Is 60 minutes the golden number? It sometimes comes down to how progressive your radiologists are. Are they really going to ask you to rescan it if we don't have full contrast through the entire bowel? Are they okay just seeing what they need to see? As long as the appendix has contrast on it, can we just move on and be happy with that time frame? The oral contrast really is the deciding factor in how we're going to shave time in our abdominal CTs. So we had an opportunity for improvement. We were a very busy emergency room, and the ED was really adamant that these 2+ hour turnaround times for abdomen and pelvic CTs were not going to cut it. And with everything in today's environment in healthcare, really length of stay and turnaround time is huge for us. And so, especially with less staff, we're trying to get as much as we can get done in the shorter amount of time that we can. waiting 2 hours just to get the results of a CT, which then the emergency department has to act upon. It just wasn't cutting it. So the perception from the ED was that we were delaying all of the care. We were the reason that they couldn't move patients through. And when they would come to us, they often said it was more than 2 hours. Data showed that it was about 2 hours, but a lot of times they were saying it's 3-4 hours was the perception. As we started working on this, as with any process improvement project, the two sides, they really were not seeing eye to eye. The ED didn't understand why we even need to use it. It seemed like a waste of time. Can we just, scan them, treat them, street them? Let's just crank these patients through. And the radiologists, they're trained with oral contrast. That's what they want. That's what they need to be able to see the images. And they were adamant that we must have oral contrast. So the ED patients with abdominal pain, they're dissatisfied because they're coming in and they're having to drink, they're having to just sit there, wait for the scan, wait for the results, and then finally get an answer so that they can receive some treatment for their pain. And that too, if it is 3 or 4 hours, that extended time, it was just making everyone upset, and there really was no winner. Sorry, went the wrong way. So our goal for this project, we wanted to reduce the processing time for patients. So we wanted to figure out how to cut down that time. Big piece was improving physician satisfaction and patient satisfaction. We were hearing it not only from the physicians, from the patients. There really wasn't a collaboration with imaging in the ED, so there was a lot of pointing fingers. The ED's hearing it from the patients. It's taking too long. So they were unfortunately throwing our department under the bus to say, well, it's the CT department. So we really needed to figure out a way that we can just improve the satisfaction all the way around. The ultimate goal is improve throughput. It's more than just improving throughput for your ROI or for your dollars for your hospital. It's improving throughput because that's what's best for the patient. They need to get the results. They need to get their care as fast as possible. So we really wanted to focus on how can we reduce the length of stay in the ED. The biggest thing that I think came out of this project and is a benefit beyond all of that is really improving the relationship between the ED and the radiology department. Instead of frustration when the phone rings, kind of getting snippy back and forth at each other, we really needed to focus on how do we work together and manage each other up instead of talking down on that it's the other department's fault that this was taking so long. So with any process improvement project, you need to have your scope. Things can really grow quickly, and then it seems like it's unattainable if you don't have your scope defined. So we did decide that this was going to be limited to just our ED patients receiving the abdomen pelvic CTs with oral contrast. So we knew that was our big delaying factor. That was our big issue. So we really wanted to hone in on those patients. The boundaries, we were going to start with when the order was placed, because us from imaging, being that this was a project led by us, we can't impact what happens before that order placed. So we decided the start would be when the order was placed, and the end would be from when the order was released for the ED physician to read. Again, how long it takes for that result to get to the patient, that's beyond my scope. That's nothing I can impact. So that was for the ER to focus on. So our boundaries were order placed into Epic and results released. So we first started with a high-level flow chart and really looking at how it's broken down. So your patient comes in, they're triaged. In our organization, a lot of the orders are ordered by protocol. So the triage nurses have set symptoms and et cetera that's on there. And if the patient meets all this, they don't have to go then find a physician and say, can I order this? They can order it per protocol and the physician signs off on it a little bit later. So we have the triage, they order the CT with oral, then the nurse has to give the oral. And that's what we're blocking as our start time. We had to look at kind of the chunks of area to understand where the true delays were. So that's what we're calling our order to exam start. Then you have probably the quickest part of the whole process is the part that the CT tech actually owns, and that's scanning the exam. So we had to really reiterate to the staff, you need to put accurate times in. I'm a CT tech by trade, and I can remember scanning, and I would just type in T minus 10 as 10 minutes ago was my start time, now's my end time, and I just would go from there. We really needed to make sure we had true data coming in. So letting them know, I really need you to start the exam at the beginning, end the exam at the end, and have accurate times in there. And then the exam ends to report release. It's as simple as when the exam was end to when that radiologist dictated that, and the report was there for that ED physician to review. So our baseline data, it really wasn't pretty. And the ED was 100% correct when they said that we were delaying. Now, granted, we have data sets all over because you're always going to have those outliers. But really, if you look at our average here, we were averaging from the entire process from when that exam was ordered to when the ED physician got their report, we were averaging about 130 minutes, slightly over 2 hours. So I guess the ED was correct when they said it's taking longer than 2 hours, but this is what our standard, this is what we were averaging across the board. We did have a couple outliers, but I'm sure there were some reasons as to why that was. But when we actually saw this data, we knew that there was something that we needed to do to cut this down. So the first step is really identifying the gaps, really not just kind of guessing, okay, I know as leaders, we often want to just go into problem solving mode and we want to say, okay, let's try X, Y, Z, but we really need to understand why is it taking so long? So first it was interviewing the staff, going and talking to the staff. What's your perception? What do you think could be improved upon? And then just going from there. So the common themes that we were hearing were just the nurses were far too busy to dose the patient. They had way too much going on. And from the point that either the triage nurse is placing the order, the physician's placing the order, it's a completely different nurse that's then caring for that patient. So they got to it when they would get to it. The technologists in CT, they had no clue of knowing when they started drinking, when they finished drinking. So they literally would just trug along and wait for the ED to call them and say, hey, patient's done drinking, and go from there. So whenever you have phone calls, back to that first point of too busy to dose the patient, if they're too busy to dose the patient, I'm going to bet they're too busy to call us to say I dosed the patient and let us start the clock on our end, or they're too busy to call us and say, hey, the patient's done drinking, you can go ahead and come get them to scan. So we really wanted to think about how do we take all this manual process out and make this something that we can see instantaneously so we know exactly where the patient is in this pathway. And that came down to multiple phone calls back and forth. That's probably the biggest frustration, even today, even having worked on this project, when we look at other areas calling into the CT department, that phone rings off the hook and I hear the frustration from the staff. If they would quit calling, I could scan their patient. So we really wanted to see how can we alleviate some of these phone calls, because when the tech is in the room, they're gonna miss a phone call. And very rarely did someone leave a voicemail. And if they did leave a voicemail, very rarely was my team checking that voicemail. The other thing that seemed like such an easy fix was at the time this project first started, many of the departments didn't have, the ED departments didn't have the contrast in their Pyxis. They had it in their storage closet way in the back. So that goes full circle back to that first point of I'm too busy to dose the patient. Well, I'm too busy to dose the patient because the contrast isn't even anywhere readily accessible for me. So it just kind of sits there until I have time to mix it. And so what we learned at the end of that is this was just turning into the blame game. Everyone had their excuses, but we didn't really have anyone taking full ownership of how to fix it. It just was this is the reason they keep calling. I don't know when to dose them. I don't know when they were dosed. It was just a bunch of back and forth, but it gave us that foundation to know where we needed to focus to improve the problem. So based on that feedback we received, we were able to really deep dive into what the issues were. And for anyone who's done process improvement, it sometimes sounds silly when you first start it, but it's really going through that process of the 5 whys. When you do this exercise with people, they'll sometimes look at you like, are you kidding me? Why are you asking why again? But it's really taking that first issue of I don't know when to dose the patient, or I don't have time to dose the patient. Why? And then when they answer you, ask why again, and why again, and why again, and why again. And that's really when you're going to get down to that granular level to understand what really needs to change for us to improve this process. So throughout all of our 5 whys to identify what is that true root cause, we realized that even though everyone felt that, oh, Epic coming in, or whichever EHR you might use is coming in, and it's electronic and we have these computers everywhere, it's going to make our lives easier, but it really doesn't. When you think, you have to have your process, and you have to have your clear line of this is where you're going to look, this is where this is going to be held. Because what we learned with Epic EHR is there's 20 different places to document the same type of information. It takes a long time, and it's not very personable, especially where some of these thin clients are in the rooms with the patient. So a lot of times people aren't documenting real time like they should be, because they want to give the patient their attention. So Epic was one of our root problems. They weren't reviewing the orders for CT. They didn't know it was ordered to even go get it. They weren't looking for the testing order because it was in a weird place, and there was no like flag at that time to say, look, a CT was ordered. And there wasn't a lot of communication. We didn't have nurses and physicians rounding together on the patients. Everyone was doing their own thing. So there was a lot of disconnect in the ED. Another big thing is there was still this back and forth disagreement on when contrast was needed. And one thing, I'm sure we aren't the only ones that would fall victim to this, of even just physicians ordering a stone protocol because we forgot to dose the patient the oral. So that's an easy way to get them scanned. Is there wasn't that understanding of the importance of why oral is needed, or on the flip side, the understanding of our radiologist that oral probably isn't always needed. So there was just still that disagreement. And so it really came down to, people are busy, they don't know the need. There's no way for us to prioritize which patients need to be scanned. Our staff was just going by, hey, whenever you call and tell me they're done. So if one nurse was really good at calling and saying, your patient's done drinking, or on the flip side saying your patient started drinking so we can time it, their patients were going to get scanned faster than the nurse that may be a little more forgetful and didn't call. So communication was huge in this. Other areas we identified was scanner downtime. We didn't want to dismiss that. We wanted to make sure we looked into that. And then just availability of our CT scanners, because we do share it with our inpatients and our outpatients. So when we went through all of that, we really said the biggest chunk that we need to look at and kind of maybe get rid of is the oral contrast. That seems to be the biggest problem. It's not really that the scanner's down. It's not that we're sharing the scanner with inpatient, outpatient. It's not where the contrast is located or the phone calls. It's the fact that you have to drink the contrast that's taking so long for these scans. So of course, we try to pull together the groups and say, hey, let's talk about this. And as I've alluded to before, we had radiologists, and some of the veteran ones felt a little more strongly that contrast was needed. And then you have the ER that's like, hey, do you really need it? Let's just scan these patients. Let's get a quick answer so that we can treat them and move on. So this really became the point of contention, and probably where we focused more of our time of how do you get your rads to kind of really, let go a little bit and say, all right, maybe all these patients don't need contrast. And then maybe by doing that, the compromise is, if the ER truly understands who needs contrast, will be a little more limited. And then that's going to cut out a huge chunk of our time with these patients. So what we did is we just asked them, okay, radiologists, why do you think contrast is needed? Provide us with literature, provide us with everything you have that says these exams need contrast. And on the flip side, we asked the ED to do their own literature research and kind of provide us, and we compared the two. And it was actually pretty neat to see when compared how they aligned. So as you look through this, there's the basics. We know kidney stones don't need contrast, but there's some that aortic aneurysm, of course, they don't need contrast, but there's some that we were probably dosing that really didn't need to be dosed. And so as we were looking through this, we thought, and no offense to any ED nurse or anyone triaging patients, but imaging orders are very complex. On the daily basis, I would say it's probably safe to say at least 10 ED orders, probably more, get revised on a daily basis because they're just ordered incorrectly. There's so many ways to scan an abdomen and pelvis. Our protocols are different. Even the order might look the same, but there's so many ways to scan them. We didn't feel that you can just hand this over to a nurse and say, all right, here's your list. So we're going to compromise on these three that don't seem to match, but here's our list of who gets oral and who doesn't get oral. So as we started looking at this and talking through, and this is one slide in this presentation, but I'll tell you, this was probably 4 or 5 meetings worth to get to this slide. So I don't want to downplay how long it took to get all of these physicians to agree. But as we started looking at the commonalities on here of what are we saying does not need oral and what are we saying does need oral, as we start looking at this, you start to see a trend of symptoms that a patient's going to present with. Kidney stones, GI bleeds, AAA, those are all kind of new onset things. Those aren't things that someone's going to come in and say, oh, I've been suffering for 3-4 weeks and now I'm coming to the ER. Those aren't those kind of situations. They're more onset acute pain type things. And then if you look down at the items that we kind of agreed on that would need oral contrast, those are more chronic issues that you've probably been dealing, or even if it's an acute flare up, you've been dealing with it for some time. So that's kind of where we started focusing on, is how do we make this easy for the ED to follow, easy for our team to follow, to say, hey, you need oral or you don't need oral, without overcomplicating it. And so really the protocol we came out, we tried to make it super simple. New onset, acute pain, those patients no longer need oral contrast. We are just going to scan them. So even I think the biggest change for our location was appendicitis. Back when I first started CT back in the early 2000s, appendicitis, everyone got oral contrast. It's really not needed. The one caveat to that is low BMIs, because they don't have that fat around to really identify if there's any fat stranding going on or anything. So low BMIs, I think we've updated the protocol to a BMI of 18 or less. So those are really low BMIs. We're not going to, we are going to give those oral just to kind of help identify the appendix there. But other than that, we really focused on, if it's acute, no oral. If it's a chronic, reoccurring type abdominal pain, those are going to match up to that previous slide. And so those are going to get your oral contrast. So just by implementing this protocol here, we were able to reduce our oral contrast usage by about 60%. So if you remember that slide way in the earlier part of this presentation where we had that 130-minute turnaround time, if I'm cutting 60% of those patients out, I already solved a huge part of our turnaround time issue right there of cutting it down. So now we have that other percentage that we need to focus on. How do we continue to tighten the gap so that we're not sitting at 130 minutes? So once we identified the glaring item in the room, the oral contrast, and we removed that from the picture, we then wanted to focus on that small chunk of patients that are going to need oral contrast. How can we improve the process? So if you remember when we went into the gaps and we identified kind of the barrier standing in the way of the ED staff and the CT staff, first, easiest solution, why is this contrast sitting in a closet in the back of the ED? Get it into the Pyxis. And that, by getting it into the Pyxis, now there's a record of when it's pulled, and that's going to show up on the MAR for the CT team. When it's sitting in a closet, you're just mixing it. The CT staff were having to scan that oral contrast was given once the patient was in the room, but there was nothing proactively alerting them. So get it in the Pyxis. When it's pulled, it now shows up on the MAR. When it's administered, the CT staff can now see it's administered. We just alleviated a bunch of phone calls back and forth. We're not waiting for someone to tell us it's done. We're not waiting for someone to tell us it's started. The CT staff can see exactly when it started, and as soon as it's starting, that's starting our clock as soon as the contrast is given. So we made sure the techs could see the MAR, trained them on that, and so now as soon as they see it's given, they're just waiting 1 hour. 60 minutes, doesn't matter how far it's passed. We've had some people say, yeah, but it took her 20 minutes to drink it. We're just waiting the 60 minutes and we're scanning that patient. We don't want to delay it. So at that 60-minute mark, we're calling the ED for the patient and we'll go ahead and scan them. So we had to make sure that we had the physician expectations as well. So we made sure that all abdomen pelvic CTs were ordered as stat. Coming from the ED, they should be, but we just wanted to make sure that they were ordered as stat. And we needed to make sure that they were stat in packs so that our physicians, our radiologists knew to read them. We reiterated with our radiologists that they need to dictate using the PowerScribe system and that they needed to self-edit. So we do have regional transcriptionists that will perform transcription, make sure things are spelled right, make sure that they use the right, they didn't accidentally say he for a she or vice versa, because sometimes the microphones will pick up a little bit differently. We said for all of these exams, you're going to self-edit. We're not sending them to transcription. Have your little caption in your report that states, you know, this is self-edit. Please, it basically says, please disregard any typos or whatever. But that was a big time savings there to not have to wait to go to transcription. Of course, the final report goes to the electronic record. And our goal that we set for our radiologists were we wanted these read within 20 minutes. So if the oral contrast is taken 60 and the reads we want done in less than 20, that's going to cut our time in half. And once we implemented this, we measured it for a couple months, and I have a little comparison there of the before, and you'll notice we have gotten it down to 70 minutes for our entire turnaround time. Again, we still had some outliers, and you're always going to have outliers. There's patients that can't keep the oral down. There's other things happening with them. Other tests, they get taken off to those. So those could be the reasons. But when you really look at the main, the averages there of where we're hovering around, we have a lot of them even less than 70 minutes, sitting at 50 minutes or what. So we really think that this has been successful and we've been able to maintain it over time. We do have drift where we have to re-educate when we have new CT staff, new radiologists, new ED physicians, etc. But it really did allow us to drop our turnaround time significantly. So to further break that out to the different chunks that we demonstrated in the earlier slides, our test ordered to exam start, that's where you're going to see the biggest impact. And really that's from eliminating that oral contrast. We were sitting at about 90 minutes just from order to exam start. That's not even the whole process. So when this first started, we were sitting at about 90 minutes. Some would get up to 115. And then after implementation, we're even below an hour on some of them of just getting those patients over, scanning them. We've gotten a little bit quicker with the physicians being not so picky where the contrast is. And then this is taking into account some of those exams that were converted and don't need oral contrast. But this is the kind of slide that shows it all of where the biggest opportunity is in this process is really if you can eliminate the oral contrast completely, then that's going to be your biggest win. So exam end to report release, while it's not a huge drastic change, just putting that time frame on the radiologist to say this is your goal, this is what we need you to meet, and asking them to self-edit, that's we still tightened up that. So they weren't bad before. Their average was about 30 minutes, which isn't horrible for an ER exam. But by adding in that caveat of we need you to self-edit and we have this goal that we're going to measure you. again, when big brother or big sister's watching, people tend to perform a little better. We were able to shave some time off there and get their average is sitting right about 19, 20 minutes, but we were able to get them down to what our goal was. So for the whole process, test ordered to report release, again, it looks beautiful. We were able to get it down to about 70 minutes, 60, 70 minutes is about what our average is now, which really isn't bad when you think of coming into the emergency department for a workup, of decreasing the turnaround time to 60 minutes. And again, this is just showing through the whole process how we had some really bad times in the beginning, but we're down to 73 minutes is our average now. And I don't think anyone can complain with that. We haven't really gotten any complaints back regarding our abdomen and pelvis scans. So to close the loop on the process improvement, if you recall in the beginning, I mentioned that we really wanted to, in addition to all this, to improving the turnaround time, improving the physician satisfaction, the staff satisfaction. The biggest thing was how can we use this project to kind of bring the two teams together so that we're working with each other, we're talking each other up, we're managing up, and we're not talking down the other department. So at the end of this, because we were pulling in core staff members in the process, the CT, we wanted to make sure we got feedback from the staff and then kind of share it with each other and continue that momentum that the two departments had together. So the CT staff, they did feel it was more streamlined. I'm telling you, anytime you can eliminate phone calls, that's a huge win for them. If any of you have never worked in a busy CT department, the phone calls will drive you crazy. So eliminating a lot of those phone calls and making it manual to where you have the ability to check and see where it is in the process and make your decisions from there, not reliant on someone else communicating with you, that's a huge win. And a big thing that seems so simple, why didn't we think of this from the beginning, was just getting the data from the MAR. I don't know why that wasn't thought of. I think a big thing is just in imaging, we don't live, nurses live in there, but we really don't in imaging, but really educating people to get comfortable with looking in there to get the information was huge for us. And then on the ED staff, perception is everyone's reality. So the fact that the physicians actually said they feel the wait time has decreased and they feel that this has improved was a huge win for us. And then the staff feel that there's reduced amount of work. They don't have to run around and chase people down and figure out what's going on because we really streamline. And in a perfect world, when the patient presents to the point that that report is released, we can do the whole process without one phone call. Now, I'm sure there's phone calls because we have questions on this, how's their IV, how's this, but in a perfect world where all the stars are aligned, you could do an entire patient and never have to call anyone from the ED, and that really shows that it has been a streamlined process. So our next steps, anything with process improvement, you're not done at the end of the project. You want to look at how you can improve better. So we did adapt this to different hospitals. I work for a pretty large health system. And so while this pilot was done at one facility, we were able to spread it out to others. And that really helps, especially now post-COVID, where we're sharing staff all over the place, that we have the same protocol. We have discussed, does it make sense to move it to the outpatient setting? That's where you still get a little pushback from the radiologist, where the feeling is, well, we did this to compromise because on an ED patient, you need instant results, you need those fast results, but the outpatients have time. But really, it's gathering that data and understanding, okay, but are you still just wanting the oral because that's what you learned in residency, that's what you learned you need, or do we really need it? Because on the flip side, when we look at patient experience, do patients really want to have to come pick that up early, drink this stuff, if we can get a diagnosis without it? So next steps is really looking at, can this protocol spread to the outpatient setting? On that same concept, can we spread it to the inpatient setting? Again, because turnaround time and length of stay was kind of the driving force in this. I think the thought of spreading it outward kind of has fizzled. But really, when you look at the experience for the patient, can we spread this? Is it really needed? And then what I'm doing today, next steps, is just sharing for other hospitals. I'm sure there might be half of you on here that are like, yeah, we did this 10 years ago. We haven't been using oral. But as I've gone to different places to speak about this, or just gone to different conferences and met other people, there are still a lot out there that are using oral contrast. So we're hoping that we can just share this and help you decrease your turnaround times should you want to. So the biggest thing was just celebrating. Anytime you have wins with process improvement, it's great to celebrate. There's many times that you can do process improvement projects and they don't pan out how you thought. You really thought the end goal was going to go to the left and you're way to the right with different things. And so staff can get frustrated with that stuff. I think it's great to celebrate, to let them know, hey guys, this is what we're doing, and really bring it down to the patient level. When you celebrate, you guys, we're helping these patients get treated faster, to get medication faster, possibly go to the OR quicker, whatever it may be. It's all about the patient. It's really staying patient centric. So we wanted to celebrate with everyone and get their feedback of, what has improved, what do you like about it, and really build upon that, because that probably, aside from the great data that we've shown that we've reduced the turnaround time, I think the camaraderie between the departments is probably the biggest win, of managing up instead of managing down. So with that, that's our process improvement. I hope that I helped give you guys some ideas, and even if it's not around this project, of just kind of walking through the process improvement format of our organization, trained some of us in lean principles. So I've been silver trained in lean, so we use a lot of those principles with these projects, and I really do think it helps you kind of get down to that granular level to understand how to improve. So whether you already were using oral contrast, if you were not using oral contrast, really go to your teams, hear from them what the barriers are, and apply those 5 whys to them. And that's really where I think you're going to get your traction on what to focus on, to make sure you're focusing on the right ideas to improve that process.
Perfect. Thanks, Jessica. We've actually got some questions that have come in. So the first question is, how did you put your radiologists at ease to trust oral contrast isn't needed?
Right. So it was a struggle in the beginning, and I still see it sometimes when we get new rads. We've had some that come in, and some are really good at it, to where they tell us, oh yeah, well, we weren't using it at my other organization anyway, so it's fine. And it's oftentimes the more veteran radiologists that have been doing this for many years. And I really think that literature review was something that helped. I still have the documents that were compared to make that graph, but showing that graph, and really remaining in contact with them of, we haven't, knock on wood, we haven't had any incidences, we haven't had anything come back where you missed something. But I really think it's just using that literature and letting them see that this isn't something I just woke up one day and said, hey, the ER's complaining, let's just quit doing this. There was a lot of thought, and so those radiologists that were involved in the process were bought in. And that was big too. I think having that one champion, we had one of the medical directors for our radiologist group was involved from start to finish. And so having that champion really does help with kind of letting them put them at ease, and read through all those journals that we don't want to read through, to kind of say that this is okay, that times are changing, scanners are more sensitive than they were back in the day. We have 128 scanners, so I mean, they're very specific with what they're picking up than if we were scanning this on a 2 slice. So I do think it's just kind of working with them and having that physician champion.
Perfect. Another question here is, do you ever have to rescan patients because they should have had oral contrast?
So in the very beginning, my staff did escalate that they felt like this was worse for the patient because they were getting requests to rescan. And it wasn't so much of that there was lack of oral contrast altogether. It was that certain radiologists were saying, hey, the contrast isn't as far down as I want it. Bring that patient back and scan. That's really where I just had to work closely with those techs to say, no, escalate this, because I don't want to put the tech in the middle. There was 2 very specific radiologists that were very hesitant about 60 minutes as being our time. And some of my techs, I know for a fact, some of my techs, they'll say, it's 45, 50 minutes. Let's call them over. By the time they get here, it'll be close enough to 60. So I know they're pushing the envelope on the time still. It really was, again, working with that physician champion to kind of go back to those 2. It didn't take us long to kind of Pareto out and notice, hey, every time you get a phone call to rescan, escalate it to me, keep track of who that radiologist is. And it really came down to 2. So I can't say I ever recall us having to bring one back to administer oral that didn't have it. More so it was radiologists trying to tell us, hey, wait another 30 minutes and rescan. And we put that to bed really quickly.
Okay, another question here is, do you have to re-educate this protocol each year?
So I wouldn't say we standardly re-educate it each year, but it is something that as I start to notice, if we've had some turnover in the ED, which in full transparency, we've had a lot with the nurses. I'm sure many of us are experiencing this right now, where we've had a lot of travelers coming through, some turnover of nurses leaving, and we're getting nurses from the floor that might just be filling in, picking up extra shifts for bonus or whatever. So you kind of can gauge it and feel it and know that we need to re-educate them, because we are a very protocol driven organization when it comes to nurses placing those orders. Our team is really good at identifying, though. They know this protocol, and I'm lucky in the fact that many of my CT techs in the hospitals that I oversee have been here for some years. So it is something that we educate upon hire, of course, make sure that everyone understands the protocol. Whenever we get a new radiologist, we of course want to educate them on it, because I did recently experience that. We received a new radiologist in our group, and we noticed that he was kind of giving the staff pushback on why there wasn't oral contrast, why they weren't properly dosing. We have a QA program where the radiologist through PACS can flag something as, this is a QA issue, you guys need to follow up on it. And as we see trends, we know that we need to educate. And we noticed that the oral contrast was being QA'd, and it came down to, oh man, I forgot to educate that radiologist that this is our protocol here. I assumed that would have been done by the radiologist group, but it wasn't. So I wouldn't say that it's a standard education of, hey, every year let's do this, let's put it in our annual competencies, but it's just something that you'll notice drift on, that we need to educate more on, or go educate one individual person. And definitely anytime the ED gets a new medical director on the ED side of things, I definitely touch base with them so they understand what the protocols. And with that, we recently at one of our hospitals had the flip side. They had a change in ED leadership, and their leader came from a location that gave no oral contrast. So we actually had the flip side of having to educate him, because they didn't even give oral contrast for the chronic things. They just scanned everybody. So he had some frustrations, and I think kind of using this on the inverse of it, of saying, okay, I understand that you are used to not giving oral contrast, but let us show you why we do. It may not be that way at the hospital you came from, but there was a lot of thought that went into it. There was literature. This is our protocol. This is why. Versus, I think that just is more palatable to take when someone tells you the why behind something, versus just saying, this is our protocol, we're going to give oral contrast. So it's just something you have to gauge, be involved in your departments, and engage when you should educate.
Perfect. Now, before we wrap up today, is there anything you'd want to expand on or summarize?
The biggest thing, and I think again, I kind of alluded to it before, is whether or not you guys are using oral contrast. I think the biggest thing out of this that I hope I helped walk you through on this whole process is just the steps behind the process improvement of identifying what your issue is that you want to address. Make sure you have your scope identified of this is out of scope, this is in scope, what are you going to focus on, and then what's your start and stop. You have to be able to measure what you are focusing on. So whether it's abdominal CTs in the ED, whether you want to focus on your PE turnaround time, your wait times for exams, it's really, you have to be able to have your baseline data and your new data to show how far you've come. So you have to have your scope clearly defined, your start and stop clearly defined, and then just work through the process of understanding what are the barriers, go through those 5 whys, really documenting what's standing in the way of achieving what I would call find your utopia, figure out what your ultimate goal is, and then work backwards from there to figure out how can we get there. Everything may not be possible to fix. If you noticed in one of my earlier slides, 2 things that had come up that were issues were downtime of the scanner and the fact that we're competing with inpatients and outpatients. Those were 2 things that we knew we couldn't fix. I can't guarantee uptime of a scanner. OEMs can't even guarantee uptime of a scanner, so we're not even going to focus on it. That's out of scope. Inpatient and outpatient volume in the hospital setting, I can't control how many inpatients need a CT. Maybe I can control if I'm doing outpatients in the hospital, but we need revenue, so we need those outpatients. So those are 2 things that kind of were out of scope for this project. We're not going to focus on for this project, and just really getting your scope, figuring out what you're going to hone in on, and then just chip away at those items until you find the real root problem. And with this project, our real root problem was simply the oral contrast. And I started the presentation kind of talking about COVID and how the contrast shortage didn't really impact us because we already had this implemented. But then when that COVID shortage happened, that kind of re-sparked this whole thing to where you go digging into your files to find this presentation. It wasn't in this fashion, but all the data from this presentation to say, hey, now's a perfect time to look and say, are we still functioning in this way? Because we can't afford to dose patients that don't need contrast. We're on a very limited contrast supply. So that just kind of shows how process improvement's never over. We had another wrench kind of thrown in the mix of contrast shortage. So we had to think about how are we going to overcome that? Well, first step, let's make sure we're not wasting any contrast on oral and make sure that we re-educate on this.
Perfect. I just had a question pop up. So can you comment on a recent education study from the University of Michigan where misdiagnosis occurred 30% without oral contrast? What are your thoughts on that?
I haven't seen that study, so I would be interested in looking up that study. As I alluded to, we have not heard of any issues within our own patients or any misdiagnosis. We have a very robust peer review process, kind of twofold. We do the peer review process, which internally we have a program that auto generates and asks another radiologist to overread certain scans, and they get a certain number per month just to make sure that there's no misses. But when there are issues, let's say from the ED, from the OR that come after the fact, we have a very robust peer review process to where all of those get evaluated at the hospital level. And I've never heard of any coming through peer review. So I think that is a very interesting article that we could look at to kind of see. And I'm wondering if that's coming because what I'm hearing is a lot of places are completely negating oral contrast, and that's where we're not there yet. And I don't know if in that study, if it talks about are they completely not doing oral contrast, or is it just on certain studies? But I appreciate whoever shared that because that is something that I would like to look into.
The lady concerned said she'll be sending you the study.
Awesome, thank you.
Perfect. All right, well, we're coming up to our time, Jessica. So thank you so much for your time today and for such a great and really interesting um, presentation. As promised, the answer to today's trivia question is, of course, Hocus Pocus. Just a quick reminder, you can attain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your One Art Category A CE credit by HIR, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@ndpublishing.com. Please visit icewebinars.live for more details of all our upcoming ICE webinars and complimentary registration. Thank you once again for your time today, and I hope you all enjoy the rest of your day.